Um, my name's Charlotte Bloodworth. I'm a clinical nurse specialist in Hywel Dda, which is West Wales. And welcome everybody to the webinar. So I'm going to be talking about managing side effects. Um, it's quite difficult to discuss all side effects within an hour. So I definitely am going to skim over things. So I've really been invited for a couple of reasons. So one, I am a WMUK trustee. So yeah, I'm also here really for my experience as well. So I've had a couple of decades working as a specialist nurse in haematology, most of which has been in the lymphoma service in Cardiff. I was an advanced nurse practitioner up until a couple of years ago when I decided to move west. So I've got a lot of experience about haematology, about 30 years of nursing experience. So hopefully I'll be able to share some of that with you. Um, Please ask me any questions that you want in the chat, and then we'll get to that at the end of the show. So I'll just crack on. Let me just find my little thing. So I'm going to talk about common side effects associated with WM and LPL treatments, practical ways to manage these side effects, aiming with really maintaining quality of life. Let me just move that little picture. Um, Also, I want to sort of highlight which side effects should prompt you to call your healthcare team, the ones that we really worry about from our point of view, and then how to get the right support when you need it. Okay, so really, before we talk about side effects, we have to talk about treatments because the side effects are very dependent on the type of treatment. So for WM and LPL, there are a number of different treatments. So first line is chemotherapy, um, and that's really a drug that is not targeted. It will kill any actively dividing cell. It's like a proper poison, if that makes sense. Regardless of whether it's a disease cell or a normal cell, it will go in and sort of kill it. We usually nowadays combine chemotherapy. So chemotherapy we've been using for decades, and it's really, really effective with cancer. Um, but it is random and quite mean in its side effects being a poison. So we do sort of improve these treatments over time, and we now add in a monoclonal antibody, which is a much more targeted treatment. So that actually targets the CD20 positive cells, which are part of the immune system. So the actual lymphocyte it targets, and that will cover the lymphocyte and make your body direct its immune system itself to killing the cell. So we've got that working and we combine it with chemotherapy, and together they're really, really effective at killing WM cells. Um, and that's why we use them. So we also now have access to targeted treatments. And again, we've got sort of one main, the BTK inhibitors that we use in Waldenstrom's. Um, you would have heard of them, ibrutinib, zanubrutinib, and hopefully a few more nibs in the future. And they again are really targeted, so they go straight to that lymphocyte cell, and certain pathways are inhibited, and the cell will just be destroyed. We also still use stem cell transplants, and that is very much more difficult treatment. Again, you have to use chemotherapy to wipe out your bone marrow, wipe out your stem cells, and then you would have previously collected stem cells that were disease-free, and they get reinfused. So that's quite a tough treatment regime as well. CAR T cell therapy, you can only access this on trials at the moment, or probably privately. It's very similar to a stem cell transplant, but your cells get sent away and modified and then reinfused to hopefully target and kill your cancer cells. And of course, steroids are really good anti-lymphoma treatment. They usually sort of kickstart the actual cell death, but they do have a lot of side effects themselves. But we do combine them with certain treatments, usually the chemoimmunotherapy treatments. So I'll talk a little bit about some of these. I'm not talking about the ones that aren't on offer, but I'm more than happy to answer any questions towards the end. So the giant question that I've been asking are what are the side effects of Waldenstrom's? And it really, really does depend on the treatment you're being given, depends on your individual health as well, and also on how your body reacts to things. And I definitely would say, from my experience, is that everybody is unique, and their responses are unique as the individuals themselves. And I think I'm still being surprised, 20, 30 years on, um, about some odd side effects that pick up or some odd responses to treatment. So nothing is black and white, I would say, in treatment. So I wanted everybody really to have a little think about what side effects, if you want to speak about anything at the end. It would be quite interesting to sort of hear if everybody's got similar things or if anybody's got anything unusual. So just keep that in your mind as I go through. So I've chosen really specific side effects. So our first line Waldenstrom's treatment is chemoimmunotherapy. So it's usually something like uh, rituximab with cyclophosphamide and dex, so RDC, or rituximab with bendamustine. And they're both chemoimmunotherapy first line treatments. And the main side effects, if I was explaining to somebody, I would say are risk of infection, immune reactions, and of course your gastro side effects such as nausea, constipation, diarrhea, and fatigue. So I'm going to talk about each of those individually. And then I also want to mention some side effects of the targeted treatments as well, because they are quite different than the chemotherapy ones. So again, bruising, bleeding, palpitations are the things that I would be asking if I was doing like a chemotherapy review. Um, and I just wanted to alert everybody, again, you probably already know about them, but each of these treatments will have some information that goes with them. So in a similar way that if you open up a packet of paracetamol, there's a very long list of side effects just for paracetamol. If you have a read of one of these information sheets about these chemotherapy drugs, there is a very long list of all the side effects. A lot of them are quite rare, but you will see a lot of sort of common side effects. And these information sheets are really useful to read. So I use the Cancer Research UK in my practice, just because it's really well written, really clear. There's also Macmillan information as well as a bit of information on the WMUK website as well. So if I'm seeing somebody that is starting treatment, I will make sure they have this information to go away and read at least overnight, if not longer. If there's going to be any choice in treatments, really, you want a chance to come back and discuss the difference between the drugs. And we also would do for best practice a written consent, and Cancer Research UK pre-fill consent forms for us to go through as well. So we would again go over all the side effects and get a signature before we proceeded with any treatment. So to me, I quite like that because you have several lines or several chances to go through all these side effects. So managing side effects, my first side effect that I'm going to talk about is infection, because to me it's one of the most risky side effects of any of these treatments. And as a nurse, if we, well, as a team really, if we're offering treatments, it's really important to highlight the risks, because what you don't want to do, is have problems because of the treatment. We're trying to treat the disease and not give you additional problems. So infection is one of the most common side effects of chemotherapy, because chemotherapy, as I said, wipes out all rapidly dividing cells, and your immune system cells actually divide quite rapidly. So they're one of the first ones to be affected by chemotherapy. Your front door immune system, such as your neutrophils, are the ones that often get hit first. You have a sort of sophisticated immune system going on with all your immunoglobulins a bit further back, and they can also be affected by all the treatments. But it's your front door sort of neutrophils that we worry about the most, because if you don't have your men at the front door, infection can be overwhelming and you can end up with sepsis. So to manage infection, so first of all, um, infection is always treated with antibiotics, but it all depends um, what your immune system is like at the time of starting treatment, and it depends on what treatment you're on as to how um, much damage we're doing to that front door. So hopefully anyone starting any treatment will be given emergency contact numbers for their treatment centre, and a bit of advice about taking a temperature at least twice a day, or if you're not feeling well, and to contact the emergency line, especially if your temperature gets towards 38 degrees. And we have a policy in the hospital that if you don't have that sort of front door neutrophils handy, that there's an hour door to needle policy with your antibiotics. And it's something I would say nationally everybody strives for, but all the problems in A&E and accessing those antibiotics in a timely manner um, is sometimes quite complex. But the sooner you get your antibiotics, the better. But obviously, if we can prevent infection, that is the ideal. Um, so I that oh, sorry, I can see my slides aren't up to date. So RSV, so that bit was about vaccinations. So you want to have all your vaccinations, um, such as, I think I've written them on the next page. I'll come back. So we use the Green Book for vaccinations. So that's what every GP will use as well. And it gets updated all the time. And it tells us exactly what vaccinations that you need. So I would say you would want, so this is um, for people that are over 65 or immunocompromised. I think I've just missed that bit off. You'd want your pneumococcal vaccination, you want your annual flu, influenza vaccine. Um, Anybody over 50, we'd want shingles vaccinations as well. Um, and there is RSV as well, which is just hidden under here, if you're over 75 as well. So the vaccinations really will give you a good working immune system in the background. We will also prescribe some antibiotics and maybe antivirals, depending on what treatment that you have, whether you're at higher risk of infections. Most commonly, I think nationally, everybody is using cotrimoxazole to protect against PCP for the chest, and acyclovir, which prevents against shingles and mouth ulcers and things like that. And then, of course, everybody knows about lifestyle. We always give the information about avoiding large crowds, avoiding people who are actively infected. Again, you've just got to be really, really sensible. If you are neutropenic, or if your treatment's making you neutropenic, so that's those front door immune system, we would recommend a neutropenic diet, and that's very much like a pregnant lady's diet. So no raw eggs, no shellfish, I'd say every area would have a bit of an information sheet about that. So I'd probably say infection especially is one of our big red flags for side effects. So we will go on about it all the time. And I think when you enter the treatment areas, they will go on about it as well, all the nurses there. So I always say if you remember anything, please remember about infection, the risk, and what you have to do if you do get an infection. So infusion reactions. So this is particular to the rituximab treatments. Um, if you're in the middle of having some rituximab, you might have a bit of an allergic reaction, and that will come out a bit. You feel hot, a bit faint, maybe a bit itchy. That's a sort of typical type of reaction. And if you look up the evidence, it sort of says maybe 30 to 40% of people will get this type of reaction. And it's a natural reaction because it's something foreign. It's a foreign antibody that we're putting into your system. So it is natural for your system to react to it. We will manage it if you're in the middle of having a reaction. We will give additional anti-allergy medications such as chlorpheniramine. We always would give some paracetamol just in case you have a bit of a fever, maybe some fluids if it's making you feel a bit faint, if it's dropping your blood pressure. But I would probably say most the easiest way to stop infusion reactions is just stop the infusion and everything does settle down. And then quite often, once you've had one reaction, you can restart and you'll be absolutely fine. And if you're not, we would just again tweak things a little bit, start a little bit slower. We just want to try to get it under the radar. And most of the time, we can get it in. We even have sort of desensitizing protocols as well if required. I think throughout my career, I've probably only ever known maybe one and a half people that we've never been able to get it in to transfuse it in properly. So rituximab and antibodies are really, really good treatment. So we really do persist with that if we can. So the ideal thing again is to prevent the reaction. We will give pre-meds. So this is the chlorpheniramine, maybe steroids, and again, paracetamol, which all sort of dampen down your body's reactive potential. We'd advise any blood pressure medication not to be taken on the first time that you have an infusion of rituximab. And that's purely because if you do feel a bit faint, if you've already taken your blood pressure medication, it just drops your blood pressure even further. So the first time we always would advise people not to take that BP medication. And the other thing is just to be aware of with Waldenstrom's, if your paraprotein, if your IgM is quite high, you can get an IgM flare with rituximab. So sometimes we don't add that in until that IgM protein is less than 40. And by an IgM flare, it means sort of you get worsening symptoms of hyperviscosity, headaches, poor vision, fatigue, not feeling well at all. So again, we don't want to make things worse while we're trying to treat. It's always a bit of a balance of doing good and doing harm. So nausea and poor appetite, again, a really common side effect of chemotherapy. Hopefully, I'd say I've got straight on to prevention. You'd have anti-sickness medication so that you wouldn't feel nauseous. Again, we sort of rate the types of chemotherapy we're giving, and we have sort of a low emetogenicity up to high and intermediate as well. So we would sort of prescribe medication depending on how sickly that chemotherapy is. So if you do have nausea and a poor appetite, we would give additional antiemetics, so additional anti-nausea tablets such as metoclopramide, cyclizine, or ondansetron. We have quite a few different types of antiemetics in our arsenal. Um, but the more we give, the more side effects they have themselves. So a lot of the anti-sickness medication can make you very fatigued. It can give you constipation. Um, so we don't like to over prescribe them if possible, but we always will have alternatives to try if that nausea is breaking through. Again, we would give fluids because if you're nauseous, you might be a bit dehydrated because you can't eat and drink properly. And we'd also get the dietitian on board so that they could give us a bit of advice about trying to improve calorie intake if the appetite is poor, because what we really don't want is people losing weight while they're on treatment. Because if you do get an infection, you need a bit of substance and a bit of fight there to get over your infections. So we would really push calorie intake during treatment. Again, the ideal thing is to prevent nausea and a poor appetite. So we would prescribe anti-sickness medication in advance, and we would advise to take it. I would probably say, hour or half hour before you eat anything or take any tablets, so that it's in the system ready. And then, of course, the advice about having small meals rather than big ones so that you don't get that bloating, nausea feeling as well. Eating snacks throughout the day, things like I always recommend like toast in soldiers because it's manageable. Um, if it's nice white bread with lots of butter, it's got lots of calories. A lot of people talk about ginger, so cutting up nice fresh ginger, putting it into hot water or ginger tea or ginger biscuits if you're feeling a bit nauseous. And then general lifestyle advice about, preventing motion sickness, not traveling, maybe not taking the bus on days where you might be a bit nauseous. And that's quite difficult for places like where I work in West Wales where you do have a big travel time to the hospital. Um, but we would try and advise you really to sort of manage your lifestyle around that. I have put a little picture up here of the Eat Well guide. Um, so the sort of government NHS do advise a healthy diet. Just move you over to that side. Um, so I would probably say this is good advice generally. So to drink 6 to 8 cups of water or fluid a day. If you're on treatment, I would probably say more the better because anything that we are killing disease-wise ends up going through the kidneys and you pee out. So the more you drink, the more you're flushing everything through. And then you want a nice healthy diet, really, with vegetables, some carbohydrates, and then a smaller amount. This is supposed to represent an actual plate and the quantities that you have on your plate. Um, Beans, pulses, meats, and then some dairy. But really, the mass really should be vegetables and carbohydrates. But I would probably say if you're feeling a bit nauseous and you haven't got a good appetite, then I would probably say ignore all of that and just eat what you want, little and often, and just think of food as fuel. If you haven't got the fuel there, you are going to feel tired to do things. So if you can fuel yourself up with calories, then all the better. So sore mouth can be quite common again with chemotherapy. So your gut and your mouth are areas of rapidly dividing cells again. So chemotherapy again will wipe out rapidly dividing cells so that the mouth can often feel really raw, can feel a bit red and inflamed. So if that does happen due to chemotherapy, it's usually only a few days before that layers back up again, that protective layer. Um, Saltwater mouthwashes are absolutely brilliant. They are the first line treatment. Um, if you look up any dental guidelines about sore gums, sore mouth, and that's really just a small spoonful of, well, a teaspoonful of salt water in a big jug, swish it around the mouth and then spit it out. Again, that will help with healing and soothing. You can get medicated mouthwashes. We do prescribe them, but I'm not so much of a fan of them. There's Corsadil that can make your teeth go a bit brown. The whole point of Corsadil is it removes plaque from your teeth. There's also a green mouthwash, which is like a Difflam, which is like an anesthetic that numbs the gums. You can have that before meals if you have got a very sore mouth. But again, to me, I think they're very both quite chemically orientated. So saltwater mouthwashes often do are often a bit better, or a combination. People often say ice lollies or crushed ice is quite nice. Soft foods, often people will tell me that pineapple is quite refreshing and soothes the mouth as well. So I'd probably say any of those things, really, whatever suits the individual for that. But what you don't want to do is stop eating. So do what you can to get those calories in for that nutrition, for that fuel. So we do like actually to try and prevent sore mouths. So we may adjust the actual chemotherapy if it's being too toxic, if it's causing too much of a sore mouth, or if it's causing things like mouth ulcers and um, problems eating, then we might actually adjust the chemo. A lot of chemotherapies, we give acyclovir as preventative medication. So not only is that good at preventing shingles, it's really good at preventing mouth ulcers as well from the herpes virus, which majority of us carry. But once we've given chemotherapy, it sort of flares up again because you've lost that immune response. And good oral hygiene, brushing your teeth at least twice a day or after meals, and then using the mouthwashes. So prevention's definitely better than management, but often you don't know whether you need to do all that prevention until you've had your first course of chemotherapy. And again, moving down the gut, chemotherapy and steroids can cause a lot of indigestion. Again, by just scuffing off the lining of the gut. If you have really bad indigestion, there are medications available. There are things like omeprazole, lansoprazole, that will coat the lining of the stomach for 24 hours and just help with that acidy reflux. And there are short-term ones such as like Gaviscon or some oral tablets. Again, we want to prevent it if at all possible. If you know you've got a tendency towards indigestion or you've had it on a previous cycle of treatment, we can give preventative medications, and that is like the omeprazole and lansoprazole that I mentioned. So not only are they a treatment, they can prevent as well. And then lifestyle, such as avoiding acid-rich foods, lots of tomatoes can worsen your indigestion. And things like that. There's a lot of information out there on the internet about what to avoid if you do have indigestion. And then loose stool. Again, I think my next one I've written constipation. So you can never really predict which way somebody is going to go. If you look at the side effects for a lot of these drugs, it will say you can get diarrhea and or constipation. So it depends which chemotherapy drugs we're using. You can often say you will probably get constipation, but you can get diarrhea. Very unpredictable. If you do have diarrhea, so diarrhea really to us is that you're passing stool at least 6 times or plus a day. And if you are doing that, really, we want you to drink as much as possible because you're losing everything. You're losing lots of fluid. You can get dehydrated quite quickly. We'd want to send a stool sample off to make sure that there isn't an infection there. Often we blame the treatments, but you might actually have a bit of an infection there. So we would advise you to send a stool sample off. If you have got an infection, you'd be treated with antibiotics depending on what infection it is. If you haven't got an infection, you can use sort of anti-diarrhea medications, such as loperamide. And with loperamide, you're supposed to take a couple of capsules at the first instance of loose stool, and then take a capsule every time you go again until you stop. And if you're really having trouble with loose stool and diarrhea, you might actually benefit from having a break in treatment. But I'd probably say again, if it's due to the chemotherapy, it's usually passing, 1, 2 days, it will pass, it will go back to normal. If you're on a more targeted treatment that you're taking constantly, it might be worth having a bit of a break in treatment. But obviously, discuss this with your team, your local team. Ideally, we want to prevent loose stool. So if you know that you have a tendency towards loose stool, we'd always advise things like plain food, low fiber diet, just in case we can sort of head off any problems. Constipation. So again, I would probably say it's probably more common than having diarrhea. Um, we spend a lot of time as nurses giving advice on different laxatives. The management for constipation really is lots and lots of fluids. Again, because the more hydrated you are, hopefully the less constipated you'll be. Keeping active as well, because you want your gut to keep working, and drinking plenty, keeping active, and taking laxatives is usually the key to everything. And there are different types of laxatives. Again, this is a whole talk on itself. Some laxatives suit some people more than others. So it takes just a bit of negotiation about the best type of laxative. Ideal is to prevent constipation. So I would say drink plenty, keep active, and make sure that your diet has got lots of fiber-rich foods in it as well, or any foods really that, again, is a very individual thing. Some people say like licorice all sorts are absolutely brilliant for them, and somebody else likes prunes. So I'd say whatever suits you, again, um, take. So fatigue, this is a massive topic on itself, and I know WMUK have had podcasts on fatigue, but fatigue is one of the most common side effects of treatments. Definitely common side effect of chemotherapy, and it is a side effect of the targeted treatments as well. So the first thing really is finding out what's behind the fatigue. So, are you anemic? Has your disease made you a bit anemic, or the treatment, the toxicities made you a bit of anemic? And if it is, you can, and if you are symptomatic because of that anemia, and by that I mean, you're short of breath, you're very pale, really fatigued, a blood transfusion may help, or iron supplements or iron infusion. Likewise, B12 or folate, which are the building blocks for red blood cells, you might well be low on those as well. So if your fatigue is due to anemia, just need a bit of investigating about what's the cause of the anemia, and then you can manage it once you get to the bottom of that. But not all fatigue is related to treatment. So it's always worth ruling out things like diabetes or thyroid, doing thyroid function tests, just in case we're blaming fatigue on treatment when it's not actually treatment, it's due to something completely different. So those investigations are really important to check if you have got treatment-related fatigue, just in case they're a bit of a red herring in there as well. If you do have treatment-related fatigue, you want a bit of a balance between activity and rest. There's quite a lot of evidence out there to say that physical activity actually helps treat fatigue. The trouble is sometimes you're too tired to increase your activity, but it is really important just setting small goals and making sure that you get a bit of activity every day. I always say to people, even on your worst day when you're really tired, just get up and walk around the house, even if it's short periods. But if you can, get out, get some fresh air. And I think the best activity, honestly, is walking. But if you do like other activities, then all the better as well. But you do need to balance that with a bit of rest. So you can't go out and go on your bike for hours and hours and then go for a swim. You do need a bit of rest as well. And you also need to make sure that when you do get that rest, it's good sleep that you're having as well. So also another way to sort of manage your fatigue is really doing a diary of when it's occurring. Can you find a pattern? Is it related to the chemotherapy? And if it is, what days in particular? If you're on steroids, sometimes the steroids make you really active and hungry and awake, and then suddenly, if you're off them, you go the absolute opposite. So if you know your pattern, it just gives you a bit of insight into managing really, what days do you need to be a little more kind to yourself, or what days do you need to push yourself on. But again, prevention is much better than management. So keeping active, make sure you've got activity in your life all the time, and make sure that you really prioritize your sleep as well. Again, I think WMUK have got a podcast on good sleep hygiene. And that's a whole podcast in itself about winding down towards the end of the day and making sure the environment is nice and quiet and dark so you can sleep well. So yeah, like I say, that's a whole talk in itself, and that's a very whistle top um, talk about that. So I just wanted to talk about some of the more side effects that are not related so much to chemotherapy, but related to the targeted treatments. There's only a few here, and I do want a bit of time for questions and answers. So I'll run through these. So the targeted treatments, in particular the BTK inhibitors, so ibrutinib, zanubrutinib, that those sort of treatments, which are oral treatments, you take a tablet a day. One of their side effects is that your blood is a bit thinner, so you can have bruising and bleeding. And in practice, this really varies. I'd say most people notice it. You might sort of knock yourself a bit more. You might have a few bruises on your arms that you can't explain, but it's usually due to, a little bit of trauma. You literally just knock your arm against the table and you get a bruise. But I have had people that have had really horrendous bruising, like the whole arm is bruised. And it's that kind of sort of bruising that we're most concerned about. Small bruises, a bit of a nosebleed or something, really it's tolerated, and you can carry on with treatment. But major things we really need to know about. But again, you need to know um, the cause. So you do need to investigate it rather than just saying it's related completely to treatment. It all depends on your disease at your start, before you start treatment, as to what your blood counts are doing. If your bone marrow has a lot of Waldenstrom cells in, you might be low on platelets to begin with. So your platelets are for clotting, and if they are low, you definitely will bruise or bleed a bit more, like nosebleeds, things like that. So we would treat bleeding and low platelets with infusions. We wouldn't transfuse unless your platelet count was under 10. So most people are sort of 150 to 400. So you have to be very short of platelets for us to transfuse. Um, but we can if needed. Uh, Also, if you're having problems with bruising, bleeding, we might manage with a medication break. If you have some of those really serious bruises that I mentioned, we might discontinue treatment altogether. Extremely, extremely rare, but it does occur. Wound management as well, because if you do bruise, maybe on your lower leg, it can turn into an ulcer if you don't look after it. And we don't want to do harm with these medications. So really look after any sort of rip skin or little ulcers well. If you're having nosebleeds, we would refer to ENT for maybe having your bleed cauterized, depending on how bad it is. But there are lots of things that we can do for bruising, bleeding. But our ideal thing is preventing. So good skin care. So what you don't want are really dry hands or feet that can crack and then cause bleeding and wounds. So good skin care is always advised. And we do advise to sort of reduce risky activities. I'm not saying completely, um, avoid gardening, but really, just be aware to wear gloves when you're gardening, especially if you like roses, that type of thing. And a lot of high risk sports, really, you wouldn't want to be playing rugby and things like that if your platelets were low, or if you were having problems with bruising on these treatments. So again, prevention is better than management. Um, but just to be aware that it is one of the sort of side effects of the targeted therapies, as are the off target effects, the cardiac effects of some of these targeted treatments. So you can get palpitations. Again, I've sort of worded these in the way that I would ask somebody if they were on treatment, do you have bruising, bleeding, palpitations? And when I talk about palpitations, really, it's really AF, so atrial fibrillation, that I'm concerned about. So your sort of heart fibrillating. If you are having palpitations, we would always ask you to go for an ECG because we'd want to investigate whether it was atrial fibrillation, or if it was SVTs, which are just like random sort of electrical um, mishaps. But we would sort of refer to cardiology for advice. An ECG literally just does the sort of electrics of the heart at an instant. So we'd want that investigating a little bit more. Um, Likewise, an echo gives us the actual sort of pictures of the strength of the muscle, and the ECG gives us the electrics of the heart. So we would investigate if there are any palpitations. But ideally, we want to prevent things like that. So we wouldn't actually start some of these targeted medications unless we had a good cardiac history from you. We'd like baseline tests. Most people do ECGs, and I think most people would ask for an echo as well nowadays. It all depends on your sort of local policies. So it's good to have that baseline information so that we're confident to start medications. And I think we can still start these medications even if you have a bit of a cardiac history. We just need sort of close advice and close monitoring. But it wouldn't actually prevent you from having the treatment unless obviously the risk of giving it is higher than the benefits that we're offering with the treatment. And that was a whistle stop tour of, oh, oh, Rachel, I think I've just stopped your recording. Sorry.
Oh no, that's okay. Don't worry. Let me just see if I can.
Get it
Oh no,
back
it's
on
still
again.
going. Don't worry.
Oh,
Yeah,
is it
it's
off
still
you?
recording. Yeah.
Okay.
Oh.
So that was,
Thank you so much, Charlotte. That was incredibly informative, and it's safe to say as well that you were able to explain some quite complex side effects in a really reassuring way. So, fantastic job. Thank you very much. If anyone has any questions, it would be great if you could pop them into the box for us. In the meantime, I have got a couple of questions from a couple of members of the community that came through via email earlier. So I'll start by reading those ones out first, if that's okay, Charlotte.
yeah, yeah.
So the first message is from a lady called Gina, and she said, I have been on watch and wait for the last 5 years and will be having treatment in the near future. I would like to know how long it takes to feel normal again after chemo or immunotherapy. I was also diagnosed with Parkinson's disease in August 2021.
Yeah. So again, this very much comes back to the everybody is an individual. So I predict that if you haven't had treatment at all, it'll probably be chemoimmunotherapy. And the two types of chemoimmunotherapy that I'd say most people offered are DCR, so dexamethasone, cyclophosphamide and rituximab, or rituximab and bendamustine. Rituximab and bendamustine is a maybe a bit more toxic. Um, that you have the benefit of maybe having a bit of a greater response from it, but it is more toxic, and because it's more toxic, maybe takes a little bit longer to recover from. And I'd probably say the actual chemotherapy will go through the system within sort of 72 days. The recovery takes a bit longer because all those cells are being killed. All those disease cells take about sort of 7 to 10 days, really, for that sort of maximum kill time. And then you're recovering after that. Usually, we give cycles of either 3 or 4 weeks, and then we start again. So it's very much a roller coaster between chemotherapies. I'd say most people sort of tell me that they have sort of a good week, a not so good week, and then a week getting back to normal. Once you've done sort of typically 6 cycles of that, it's then just pure recovery. So most people will bounce back quite quickly, um, but it depends really what we're talking about. I'd say fatigue is the one side effect that hangs around for a long time. Again, very individual with that. Um, your immune system should recover within your sort of frontline immune system should recover within a couple of weeks, but all that sophisticated stuff behind the scene really takes at least sort of 3 to 6 months to catch up. So it all depends really on how strong you are before you start chemotherapy, how fit you are in general, the type of treatment that you have. But I would say very few people bounce back, healthy and feeling strong quickly. It's definitely harder than um, I might say, if you know what I mean. I might be very breezy with it, but I do really see people take a while to recover. Is
Thank you, Charlotte.
that's
Thanks.
fine.
I think Gina, I think you're on the webinar. Is that okay? Okay, sorry. I think it's because I've muted everyone. I could always
Oh,
send you a message after the webinar. So, and then the next question that I have down is from Diana, and she has said, "I've had a rash on most of my body. I saw a dermatologist, and it is much better. Is this unusual? I have WM and just started on zanubrutinib."
yeah. So I'd say it's not a common side effect of zanubrutinib. So I think you can get a rush with BTK inhibitors. Um, they often can settle. The rash also might be from some of the supportive medications. So I'm not quite sure if you're on zanubrutinib with cotrimoxazole or allopurinol. Those are drugs that we often give, especially at the start of treatment, and they're usually culprits for a rash, allopurinol and cotrimoxazole.
Charlotte,
Um,
it's Diana. I actually
Hello.
had the rash before I started zanubrutinib.
Ah, okay, okay. And
Wow.
did it get worse or settle?
What, since I've been on zanubrutinib?
Yeah.
Um, I still get odd bits of it, but I've now got some ointment that I can put on it that the dermatologist gave me. You know,
Okay.
but I just wondered if it's a sort of common thing or am
Oh,
I unlucky?
yeah. So I'd probably say I would say it's not a common thing. It's not one of the common symptoms of WM. WM, I mean, it's part of all your immune system. So it can get sort of your immune system can act abnormally. So it would be interesting to see if it does calm down once you're established on zanubrutinib. And then I would probably say maybe it was.
Yeah, well, the dermatologist thought it could be linked before,
Yeah,
so
yeah. I think yeah. See if it goes away with treatment, then maybe it was, but it's definitely not a common thing that I come across a lot.
thank you. I just wondered, thank you.
Okay.
Thanks, Diana. So looking in the chat box, the first question is from Karen, and she asks, what happens in a cytokine storm?
Okay, cytokine storm. Yeah, so I'd probably say cytokine storm are most related to the CAR T treatment. So I don't know whether that sort of question has come from that, and that's really where your body just goes into overdrive. Really, you will get a high temperature, your blood pressure might drop. And if you really get that cytokine storm, you feel quite unwell, and you do need something to control it, get it back down again with steroids, fluids, that type of thing. So it's a very rare side effect. I think really with CAR T treatment, it's about like I don't know, I can't quote numbers, um, but it's very rare, and they grade it differently. So you might just have a bit of a temperature right up to a complete cytokine storm where your blood pressure drops and you need actually admitting to ITU for sort of support. But it is reversible. And the thing they say about a cytokine storm is nip it in the bud because the earlier you can stop it, the less serious and the less ill that you feel. So very rare cytokine storm. But it's a reaction to the drugs that you're having.
Thanks, Alice. Uh, Penny has asked, how do I know if my fatigue is related to my ibrutinib treatments or just getting older? I'm now 72 and been on ibrutinib for many years.
Yeah, so it's really difficult fatigue. So I would probably say it's a number of things. So the treatments, WM itself can give you some fatigue. Treatments can give you some fatigue. Getting older definitely gives you fatigue as well. And if you pick up any other sort of comorbidities, diabetes, that type of thing, it's just a little bit of everything. And the older we all get, the more things that we pick up that do make us tired. So I'd probably say in part it's related, but it wouldn't be the whole thing. If you suddenly stopped ibrutinib, you still probably would be fatigued.
You. And Andre has asked, which treatment affects neuropathy?
Well, I suppose the disease itself can cause neuropathy. So a lot of the time we're giving treatment to prevent neuropathy with WM. Um, so I'm just trying to think. It's a lot of so it's not those drugs that I've mentioned before. So cyclophosphamide wouldn't, bendamustine wouldn't. It's drugs like vinca alkaloids, and treatments for other sort of hematology diseases. So I would probably say there aren't any drugs that would give you peripheral neuropathy. It's more the Waldenstroms. That's would be my answer there.
Robert has asked, oh, sorry, he starts off by saying, Charlotte, thanks for a great presentation.
Thank you.
When starting on BTK treatments, is it typical to get more side effects to start with, and then they hopefully tail off as you get more used to them?
Yeah, definitely. I think it always takes the body a bit of time to adjust. Starting treatments, some people might get headaches with BTK inhibitors, and they always settle. It's very rare that they become a long-term problem. Some people also may be a bit nauseous. Again, always settles. Joint problems as well. Sometimes you can get joint problems with BTK inhibitors, usually at the start. Again, they usually settle. So once things get established, usually you're either managing them or they're resolving and your body's getting used to them.
Graham has said, I've recently started on zanubrutinib. The main side effect I have now is aching leg muscles, but I do still walk every day. Is there anything that can be done to alleviate this?
So you're definitely doing the right thing in keeping active. So again, I'd probably make sure that it is related to the treatment and just make sure you haven't got any other problems like circulation problems. I would also say a lot of treatments pick on your weaknesses. So, if you might have joint problems or things like that, sometimes the treatment can just bring them to the front. So it's always worth um, making sure they're investigated rather than just saying, no, it's definitely the treatment. If it is the treatment, if you've had a few investigations and it is treatment, also you want to pin down to what treatment, because sometimes the other medications, the supportive medications, can give you leg aches if you're on any antibiotics, anti-nausea medication. But my advice would be to drink plenty as well, because the more you drink, if it's anything sort of related vein wise, it's always good to drink and stay active. Um, Red flag would be if you get one leg in particular that's swollen, hot, red. I'd worry about a clot. But if it's both legs and they're a bit achy, then hopefully it will just settle down if it is related to the zanubrutinib.
Charlotte. The next question is from Alan. He says, thank you for the most useful insight, but I have a question about diet and infection combines. Alan, would you like to ask your question?
Yeah, please, if I may. Is this coming out
Yeah,
okay? It's my first time using this, so
it is, yes.
um, thank you. Yeah, first of all, thanks ever so much for great insight so far. To be fair, I have a question that's now kind of actually become more of a question than it was before. It's increased my fear a little bit about infections. I currently have an underlying issue. I already have a bowel issue, diverticulitis, which I already take lansoprazole every day, and I'm on it's like a circle of life sort of thing where I take loperamide for a few days to stop loose stools, but then obviously when you have too much loperamide, it bungs you up, so to speak, and then you end up tearing internally and bleeding occasionally, and you're open to infections, which until such time as I start on any chemo type medication, my body's capable of fighting off the majority of the time on its own. But obviously, going on to chemo when obviously I should be like a much lower tolerance to infection. Um, Obviously, that's going to affect me quite a bit more. But then I've looked at your the diagram that you kindly put up online here earlier with regards to the good diet. And the good diet that I have for my diverticulitis and pipework issue is a total conflict for what is a good diet, according to the lady I see at the hospital with regards to my WM diagnosis. And particularly anything with seeds in is a nightmare for causing and getting infections in the bowel. Um, but obviously, I've been told that some of these seeds are like some of the best things I can have for helping with the WM. So, do I look after the top? Do I look after the bottom? It's kind of like one end conflicts with the other, and I
Yeah.
don't know which way to think on it.
Yeah, I mean, I would definitely say you need specialist advice. I think the normal diet, my nice little plan from the government, probably doesn't fit you. So you want to find an individual diet um, plate that's good for you. So I think investing time in that now, before you're on treatment, is worth doing. Definitely. And I think I would say we have lots, everybody, you're not the only one that's got individual um, issues that you're concerned about in a way. I would say everybody's an individual, and sometimes um, well, I would say you would be treated individually. You'd have a low threshold for antibiotics. We'd make sure, in a way, you'd have good advice about skin care, that type of thing. And I think it's worth investing now before you're on chemotherapy, if you've got that luxury of a bit of time now in preparation for it. So getting plugged into those prehab teams and the advice and things is definitely beneficial for you, I would say.
I appreciate all your useful and helpful advice. And if it's of any consolation to the good lady that spoke a short while ago about having the rashes, I'm on no medication at all. I was referred to the dermatologist, and he just basically turned around and said, "Oh, it's eczema," when clearly that was not the case. And that's the last I've heard of that. And I'm not on any sort of medication yet with regards to the WM.
Yeah, yeah. Well, maybe I mean, I don't know if WMUK can maybe help source some advice or, some alternative way of finding that sort of specialist advice that you need. I think it's worth
Appreciate that.
carry on.
Yeah,
I
of
think don't
course.
give up if you just get one sort of knockback saying there's no problems. There obviously is something that needs attention, and it's good to keep pushing.
Thank you very much indeed for all your advice.
Yeah, definitely, Alan. If there's anything that we can help you with at all, I could always speak to you tomorrow if you like and see if there's any way that I can hopefully get some support for you.
Thank you so much. Thank you.
Okay, thanks, Alan. So looking at the time now, thank you to you all for joining us. It's absolutely brilliant. I can finish with a really kind comment from Penny, who has said, "Thank you so much for the fantastic difference you have made at Withybush Hospital," which is
Oh,
lovely.
That's really kind. Thank you very much. I'll have to pay you later.
So yes, thanks again to Charlotte. You've been you make an incredible difference, so it's really appreciated. And thanks to all the community as well for joining us. We've had a great turnout. So yes, thank you.